what is the method for evaluating how effectively we've been able to address the problem? We also need to come up with measurable metrics about what it means to achieve health equity. Right now, we don't actually have a measurable definition of equity that we use here at a national level. So we need to utilize equity or inequities and disparities as a measure and a metric of success in terms of how are we doing to address these issues and problems.
So, with all that being said, as someone trained in the field of public health, one of the health outcomes that we are preoccupied with is death. And as an epidemiologist, we want to understand the causes of death. So this observation that death is not distributed evenly in a population is not something new. This is a quote by Rudolf Virchow, who is commonly considered to be one of the founders of the field of social medicine. And he said, medical statistics will be our standard of measurement. We will weigh life for life and see where the dead lie thicker, among the workers or among the privileged. So one thing that I appreciate about this quote is the reference to the social determinants of health. Again, the privileged or the working class, the rich and the poor, wealth, poverty, the advantaged or disadvantaged. These are age-old issues that still have strong relevance today. Another period of US history that has important implications for racial inequities in health is slavery. This is a map of the concentration of slavery in the US South. Slavery was quite common. About 1 in 3 white families owned slaves in the US South. But here again, the concentration of slavery was not distributed evenly. What Michael Kramer and colleagues found is that current day patterns in heart disease mortality map onto differences in slave concentration. So disinvestment in areas with larger former slave populations have led to structural disadvantages that continue to have ramifications for health today. But how can we quantify how racist an area might be? One approach that I've used in my work is to look at Google search volume for the N word. In multivariable regression models, we found that each standard deviation increase in this Google query-based proxy of area racism was associated with an 8.2% greater Black mortality rate. 8.2%. This is equivalent to an excess of 30,000 Black deaths. 30,000 Black deaths annually. And again, this is just one particular facet of racism, racism more broadly as a system or an ideology. And so racial discrimination probably falls under the category of personally mediated racism. And the field, I think, rightfully started with examining racial discrimination, because the experience of being treated unfairly is an obvious consequence of racism. It's measured most often, at least in the public health literature, through self-reported survey, self-reported instruments. These measures have typically assessed experiences of racial discrimination in housing, in education, or in medical care. There are also measures that assess more routine, chronic, and everyday forms of racial discrimination, such as being treated with less courtesy or respect, receiving worse service at a store or a restaurant. And these measures have typically focused on the frequency of these experiences, so how often they've experienced racial discrimination. Less often measured, though, are assessments of intensity or severity, people's appraisals of these experiences, such as how distressed or bothered they were by these experiences. One particular outcome that I consider in my work is telomere length. Telomeres are repetitive sequences of DNA that cap the ends of chromosomes and shorten with each replicative cycle. And in this sense, telomeres have been posited to be an indicator of one's biologic or cell age. In this particular study, we looked at the relationship between incident experiences of racial discrimination and changes in C-reactive protein, or CRP. CRP is a measure of inflammation, which is fundamental to the pathophysiology of lupus. And in short, what we found is that new experiences of racial discrimination was positively associated with changes in CRP across this 2-year study period. We also assessed what's known as vicarious racism. So vicarious racism involves seeing or hearing about the experiences of racism of other people in one's racial group. So, for example, witnessing instances of racial insults, racial harassment, police brutality. And these findings echo other research documenting the mental health consequences of highly public instances of racial violence.
So, when we think about reflection on health disparities, I think one of the first things that comes to mind is the social determinants of health, which we've been talking about in this country for over 40 years. But nevertheless, we continue to see ongoing health disparities. And I think part of the reason why is because while it's very important to recognize the role of social determinants in determining health outcomes, I think what we don't talk enough about is how racism is very much the determinant of these determinants. And by that, I mean that the type of education you're going to have access to, the level of economic stability you will have in your life is very much determined by the amount of racism that you experience. And so racism is kind of on the outside, influencing these social determinants of health, which in turn are influencing your ability to have healthy outcomes. And of course, it's not just the pollution that is disproportionately distributed within communities of color, but there's other environmental factors. For instance, advertisements. I'm sure anecdotally it wouldn't be surprising to most of you to think about how many more fast food and tobacco advertisements there are in low income communities and in communities of color in comparison to other neighborhoods. For instance, this infographic is showing us that there are 10 times more tobacco ads in Black neighborhoods than other communities. And so when we see disparities, for instance, in smoking, we have to factor in the availability of tobacco and the amount of tobacco advertising when we're trying to figure out how to address those disparities. And then it's not just advertisements. The last couple of years have shown us the ways in which, in particular, Black families can't be guaranteed to have access to healthy and clean water, which feels pretty basic in the United States. And yet, when you look at the majority of communities in this country that don't have access to clean water, they're overwhelmingly Black, Indigenous, and Native Hawaiian communities. And then another environmental factor that I just want to name is homelessness and how disproportional being unhoused happens to be in comparison to race. For instance, in San Francisco, you can see that nearly a quarter of Black pregnant people did not have a place to sleep during pregnancy. And that's not compared to a white average, but rather an overall San Francisco average of only around 3%. Healthcare is another critical component of social determinants. Even if you have access, for instance, to Medi-Cal or Obamacare, it doesn't necessarily mean that you're going to have access to healthcare. I will also point out that in this country, Black and white people tend to use drugs at more or less the same rate. And nevertheless, when we look at incarceration data, what we see is a huge disparity in terms of drug arrests based on race. We are particularly interested in looking at food security, housing security, and maternal stress. Also, mental health for the moms and the babies, economic security, kindergarten readiness. And then something that I'm really proud of is we're really excited to look at the mom's sense of well being, hope, and agency.